You're listening to Ride Along, EMT School. I'm Mike.
And I'm Max. We're two students navigating EMT school, bringing you along week by week.
And I'm Jonathan, a paramedic bringing real-world perspective.
Join us as we share the lessons, challenges, and stories from EMT school, and hear insights from those already living the EMS life. Welcome to the Ride Along. Oh, we're here.
We are, all of us.
All of us. Well, hey, where'd you come from? Hey.
All the way from the mountains of North Carolina. I'm here.
Oh my God. The hillbilly has arrived.
I had to walk a lot of hills to get here.
His feet are tired.
They are. So is my back.
You're like Frodo. You've traveled all across Middle Earth to get to the mountains of Mordor.
The winter wasteland that is Pennsylvania.
Yes.
What's that path that where they go over the mines of Moria? I think they go over the mountain. I can't. I'm a nerd. I'm totally a nerd, but I cannot remember all these little details from like the Lord of the Rings.
He should be ashamed of himself.
I should be ashamed of myself. I can remember some characters, but man, there are some people that can spout off every little thing, like detail about those movies.
Right.
Did you ever see? There's this guy on Facebook. He does these shorts where he's an aircraft mechanic.
Yeah, he's awesome.
Yeah, I love him so much. I don't know his name. I'd totally give him a plug. I'll look it up and put it in the notes. But he's an airline mechanic, and like he'll often like take a picture of like, you ever been on a plane when it looks like there's smoke coming out of like the ventilation system where it's like water vapor or whatever. And he goes, you see this here? This is like, some people think that this is a problem, and this is actually water vapor that's coming out of the ventilation system, kind of like when Erwin, pulled killing weed out of her mouth from chewing it and putting it to Frodo's shoulder in the mines of Moria. I know I'm messing up all of these parts of the story, but like he just rolls from like
it's great,
like aircraft mechanics straight into an analogy of how it's like this really obscure terminology from Lord of the Rings.
Oh man.
I'm like, this dude, he hits on like aviation and Lord of the Rings is like the nexus that satisfies a very large part of my brain.
And he does a deadpan, like monotone deadpan, which is even better.
Yes, because it just rolls off for him. But yeah.
Well, welcome, people.
Welcome, everybody, to the Ride Along EMT School podcast. This is episode 22.
Ooh.
22 episodes. We're getting there. We're almost EMTs.
Close. So close.
We've only got like, a third left of the class. Or the topics.
Before you know it.
Yeah. We're getting through all these medical emergencies, right? Tonight, we're talking about the abdominal.
The abdominal.
The abdominal emergencies.
There's not much in there, right?
4-quadrant death hunch. That's the name of tonight's episode.
It's a good one.
It is.
It's a good one.
Yeah,
it is. It's nice.
Sometimes I like the
He's not singing though. I'm still disappointed.
I couldn't think of a good I bet you we could totally come up with some lyrics for a 5-finger death punch song.
I'm sure you could.
Probably.
Like I bet you there is a song somewhere. If you started reading it like without singing it, it'd be like, this sounds like it's from my textbook. Blood gushing from the stomach in the I don't know, but yeah, we're talking about abdominal emergencies tonight.
Yeah, it's a pretty complicated space with lots of stuff in it.
A lot, yeah.
Yeah, it's got all the things
that are important.
Yeah, the abdominal.
Yep.
The abdominal. It has a lot of things in it. It's got like all the things in it.
Yeah.
Like
it's got a bunch of stuff.
All those squishy organs.
Yeah.
But yeah, so we've got a lot to go through tonight. All talking about things that okay, by the way, I'm going to ruin this for everybody who's listening right now. I'm going to jump to the punchline of tonight's episode. We can't do much.
Nope.
There's not a lot that we can do in this particular space.
Load and go.
Just pick them up and and run like you stole them.
Yep.
Pick them up and run like you stole them. Yeah.
Listen to them
man.
bitch, whine, and complain about how they're in pain, and put them on a gurney where they're even more uncomfortable, and take them to a place they're stressed out about.
Yep. It's we're very much focusing on identification.
Mm-hmm.
You know, what can we pick up as EMTs in the field? What what red flags can we identify and help relay down the line? And, you know, how fast can we get them there? Like, because abdominal emergencies are something that needs attention usually right now. Like, it may not be deadly right in this second, but it can go south very quickly.
Sure.
So
Yeah.
we'll talk about that a bunch. But yeah, so how are things going with you guys though, by the way? Like we've all been doing some stuff lately.
Yeah.
We've all been working.
Mm-hmm.
Max, you've been putting in some hours at the as a volunteer, right?
Yes. And finally getting some context out of it. Finally.
How many are you at?
5.
5 out of 10.
Yep.
You're halfway there, buddy.
I am. I'm halfway there, and I have like 4 weeks to find the rest.
Yeah. Well, it's putting the time in, I guess, right?
I'm just gonna start grabbing like random people off the street and injuring them and saying, "Okay, what's wrong with you? What's your name? What did I do to you?
yeah, I
What's
guess
your chief complaint?"
I guess if you go by the name, like it's a patient contact.
Hey.
Like it's
He was a contact. Now he's a patient.
I contacted him with my hands.
Oh, man.
I'll vary it up: hands, rubber hose, whatever.
Max. I finished mine up. He
did.
I got to 10, and I was like, oh, because I went from 1 to 10 in the matter of like 2 weeks.
Yes.
Because I was at 1, and then I did 3 shifts in a row, like 36 hours straight of no calls.
Yeah.
Volunteering across 2 different services. And I'm like, oh, this is going to be a long stretch.
Didn't I tell you guys that you were going to have to like scratch, claw,
Yep.
and fight for every single contact?
You
Yes, you
Yeah.
did.
Yeah.
So
It's
I
almost like you knew what you were talking about or something.
Listen, it's only because I have the experience.
Yeah. you are the wise sage.
I don't
Yeah.
know about wise, but you know,
You are the
I've been around a
sage.
while.
You may not be wise, but you're ours.
Yes, exactly.
But yeah, I finally finished up. I knocked off my last 2 on like a night shift, and I promptly hung up the spurs, and I'm never going back. No, I'm
Yeah.
joking. I've had 2 shifts since then, and I'm just going to keep going because that's what we should be doing. The whole point of doing the patient contacts isn't like, oh, you should just get those and then be done.
Oh, wait, what? Wait, what?
You're right. Like, it's almost like it's the bare minimum that you should do before
Yes.
you actually, you know.
I'm never touching another person ever again.
Yeah.
We could only hope.
I do have something to look forward to. I did when I was at my service the other day. Our chief came by and we were chatting. He's a great guy. Like I've been really happy meeting pretty much everybody at most of the services, like both services that I'm at, and we were chatting about, hey, you know, how far along are you? Like, what's next? What part of the program are you in? When are you doing your evoc? We've got evoc coming up in a couple of weeks.
We do.
What is evoc, Mike?
Evoc is it's an evil character.
It is.
Lord of the
No.
Rings.
It's a little furry guy that has a spear, right?
Right, yeah, he's
Right.
like he's the one they roast Darth Vader over this. No, evoc is emergency vehicle operator course
Course
certification,
Yeah.
whatever you want to call
Either
it.
or.
It's what we do so that we can drive the ambulance.
Yeah.
Do we
So it can be safe to do it.
Do we get to do J turns and stuff?
Negative.
That handbrake turns though. That's totally. I read that in a maybe it was like the proper use of a handbrake. I've just figured that meant like handbrake turns.
Always
wait.
put the parking brake on and
Yeah.
always
Yeah.
chalk the wheels.
Always chalk the wheels, right? Yeah, I'm sure everybody always chalks the wheels every time they get out of an ambulance.
Listen, man, you got to sometimes work some places. You got to do it.
Do we drive through Virginia and give like the finger to the cops as we drive through with the lights on?
I don't think that's going to wind up well for us. I don't think I've heard that that getting pulled over in an ambulance is probably not beneficial.
You have.
You don't want to do it.
Yeah.
Yeah.
I would imagine
Not my
that
mistake,
doesn't-
but
that
somebody else's perhaps.
Yeah, I would imagine that doesn't wind up well for most people.
No.
But yeah, so we're doing our emergency vehicle operator course in a couple weeks. Max and I are signed up for that one together as well.
We are.
And we're, I don't know, I'm kind of looking forward to it. So my chief was like, when you doing that? Okay, great. When you get that, you can get some practice here, start driving. Cool. And then, he's like, okay, cool. And once you finally get your certificate, we'll roll you right into evaluations and, we'll get you rolling. I'm like, oh, okay. So I guess I've made some sort of impression that they don't want to like kick me out of here. So that's good. I'm going to count that one up as a win, that they have some level of wanting me to like, actually do the EMT thing once I'm an actual EMT.
So, Mike, the cones are not points.
Oh, in the vehicle course?
Yeah,
No?
you want it. Yeah, when you're taking EVOC, the cones do not equal points.
What about pedestrians? Children?
They do not.
Dogs?
Can't either.
Cats?
That's an immediate failure, Max.
Critical fail.
Critical foul. But I ran him over, like centered him.
I got all of them. I can see Max right now, but I hit all of them.
Every single one.
I was very consistent. Yes, you were. So yeah, we got a lot of fun and exciting things going on.
I've had some exciting calls.
Yeah, like what?
Nah, like I've had the long scope of things from boring to extreme to
Yeah,
So
You-
that's
well,
been interesting. I've
you've
had trauma.
Yeah, the trauma one
Yeah.
was your first call ever.
It was indeed. Yeah.
and then unfortunately, you've had some kind of
I
grim
have.
ones, like suicides, right?
Yep. That was this weekend. Like that was different.
That's a rough call
It's
to
rough,
go
man.
on, especially as a student.
Yeah. So it's been like, oh, this guy sprained his knee to that person is no longer living.
Yeah.
And there's nothing I can do about it.
Way to bring the mood down.
I do what I
Max.
can.
Yeah.
I mean,
It's my role,
geez. I mean, I've been lucky enough to see I saw a level 1 trauma. Level 1 trauma. Got to see like a little old lady who messed up her forehead. She fell in a parking lot, hit it on a bumper, and like that qualified for level 1 trauma. So I got to see like her being rolled right into a trauma bay, which was like, oh man, this is highly coordinated. Like everyone's literally have spots on the ground.
Yep.
With their names on it, like, or their positions, like
They are all about business.
yeah, like this is where the emergency medical attending stands. This is where the charge nurse stands.
Right.
This is where the respiratory therapist stands. Like
Right.
it literally has a dot on the floor with
Yep.
their title, and I'm like, oh, this is actually a level of organization that I am quite
Mike's like,
impressed
this
with.
feels so good.
Well, it's preparation, man. Like it seems really like interesting to see that level of performance, But yeah, like everything from that to I guess I got to pick up, the 86-year-old gentleman from the old folks home,
Yep.
which is
Hey,
a
man,
lot.
listening to you guys tell me about your patient contacts as you've gone through this, you guys have had a good smattering of types of calls.
Yeah.
Yeah.
That's and really that's what you want as you're going through EMT school.
And it's because I think we're sticking with it, right? Like
Yeah.
we're not just hitting it, quitting it,
Sure.
We're I think both of us are very much I think we're kind of pulled in.
Sure.
We're in it.
I'm enjoying it.
Yeah, I like it a lot. I really want to keep progressing with it. But
He's going to be a medic. People just keep putting the pressure on. Send your letters in. Send your notes in. Keep buying monsters. Every monster you buy is another day of medic school for him. Like
somebody wants to sponsor me, sure, I'll go through whatever schooling. Somebody's like, yeah, well, we'll pay for you to go to school.
can you imagine like walking in medical school and you have this shirt on? Bill sent me here.
Yeah, I'll wear sponsored shirts. Like I'll look like a NASCAR driver
Yeah,
walking
right.
into medical school or
Bob's bait and tackle.
yeah, Bob, you're a good dude. Like, I really appreciate the sponsorship. Actually, I have been considering doing AEMT. Now,
Yeah.
I know Jonathan's coached me a
Do you see
time
the
or two.
disappointment in his face?
Now, here's the thing, and I don't know if you know this. In Pennsylvania, I have to look into this more,
Sure.
but there's a bridge.
Okay. So in Pennsylvania, there is a timeline process that you've got to bridge.
Yeah, so I've talked to a couple of AEMTs at my service.
Uh-huh.
And I didn't realize that this existed, but they're like, well, the reason they went to AEMT school was because they can then use that as a significant portion of a bridge into a paramedic program.
And it does make sense. A lot of
That I would do.
places do that. Depending on your paramedic school, they will start with that. You know, you come in as an EMT and they will start the curriculum, and at some point during that process, you will test as an AEMT, and then go forward, and you know, you're kind of killing two birds with one stone as you're doing it. And it's a great listen. I appreciate good AEMTs. They really are helpful to services that have limited resources.
Mm-hmm.
And we have, you know, some of the agencies that I've run with, we run a lot of AEMT staff trucks, and a lot of those folks are really good at what they do.
Yeah.
You know, it's a great way to build some skill over some time instead of jumping straight in to paramedic school. But if somebody were listening and wanted to make this their career, you know, they're a younger person, or, you know, even somebody older, and they wanted a change in career, and they're ready to jump feet first straight to paramedic school after EMT school, you know,
that would be the preferred method of, like,
Right.
for me. Like, I would rather just kind of go zero to hero, right? Like,
Sure.
EMT straight to paramedic as quickly as I feel comfortable doing it. But I don't know. I got to figure out how I can.
He's not shaming me into medical school.
Let's not
happening.
let's not put the cart before the horse,
Like,
guys.
I got to get through EMT.
Let's get through the national registry first.
I like it though. I have aspirations. Let's put it that way.
Hey, goals are good to have, man.
Yeah, I want to, like, I don't want to stagnate. Like, I don't ever want to get to a thing like, oh, I'm an EMT, that's all I'm going to be.
Sure.
Like, I want to keep pushing.
Well, and the thing about it is, it takes some time to build up proficiency as an EMT.
Mm-hmm.
And, you know, I encourage folks to take a little bit of time. You know, if you know you want to be a paramedic, that's awesome. But take a little bit of time, get some experience, get some calls, you know what I mean?
It's critical.
And that's only going to help you in the long run.
Right.
So,
I think generally the more experience you get in the street, you
in
know,
the streets.
in the
On the
streets,
main streets.
you know, really getting in there, getting your hands covered in blood and you know,
viscera.
viscera.
Not if you're wearing your BSI.
Yeah, BSI scene to say. But I think that's obviously going to be the best way to learn. Like, schooling is good.
Mm-hmm.
It gets us so far, but there's nothing like solidifying it in while doing it.
Just
Like,
let me touch it.
You need to. Well, what? You need to get out there. So I guess this is our way of saying, you know, we hope that if there's anybody out there that has taken the leap, that you're contacting and finding a service and having some fun with it, and, you know, learning some things
Sure.
on the job.
Absolutely.
And most of them out there, whether or not you are or are not in school, are going to let you, like, ride along in some way.
Sure.
So definitely get a feel for it. See if it's something you like, and then stick with it. Be an asset. You know, be a good helper. You'll learn so much. Like, it has solidified so much of the things that we've learned in class. Just riding
100%. Yeah, being able to see it in action, or seeing the decision making in action, and be like, oh, okay, yeah. That's how 1 + 1 = 2.
And even the technical or the hands-on skills.
Oh yeah.
The other day I was riding and I felt so good because I was being so helpful. Like, we had a call where it was kind of nondescript. Like, it was a medical call. We didn't know what was wrong with the guy, but the AEMT who was with us, was kind of getting task saturated. Sure. It was she's new, and she was like, she's trying to do everything herself. Sure. I'm like, hey, give me that. Like, like she was like, oh, can you do a blood sugar? I'm like, I could do a blood sugar. Like, hell yeah. Like, hand me that. And I'm like, and she's like, oh, I need to get a blood pressure. And she starts, I'm like, oh no, give me that. I'll do the blood pressure cuff. I'll get the SpO2 meter on. I'll do the 4 lead, and then I'll do a 12 lead, and then I'll do the I got a blood glucose level on them. And it got to a point where I'm like, how can I help next? Like, I was like, oh my God, I feel like I'm actually like I'm getting a rhythm.
I'm not an anchor.
Yeah, I'm not. I'm an asset.
and that's a great progression. Like if you think about when we were first talking about your contacts and your first ride shift, where it's like, wow, when do I jump in? What do I do?
Yeah.
Versus
what do I do
now,
with my hands?
Right. And now you're like, oh man, I can do all the things.
Yeah.
So that's great.
It feels good. It does. But as a segue, that call, learning to help get some diagnosis, getting some vital signs, it was actually on a call that was very closely related to today's topic. Mm-hmm. He had some nondescript belly pain. Sure. This 86-year-old male. And don't know exactly how it turned out, but I can see that there was a protocol in place of like, hey, these are the things that we're going to be looking for and questions that we're going to be asking and things that we're going to be trying to suss out from their condition, from their pain, to figure out if they're having a more severe emergency.
Sure.
And that's what we're talking about tonight in abdominal emergencies, which will lead us into today's medical term of the week, which is peritonitis, which is, I don't know if you guys know this, but it's the lesser known brother of Leonidas.
Right.
Instead of bringing 300 to Thermopylae, he brought 5 to New York City. Like, gotcha. I don't know. It's just like, it was a very lesser known battle.
Right.
Of the pizzeria.
Of the pizzeria. I don't know. No, it's obviously peritonitis is it probably has a Greek origin because it's
like everything else.
Yeah, everything else. But peritonitis is inflammation of the peritoneum, which obviously is self-explanatory. No,
of course,
because you're like, okay, thanks, Mike, for defining peritonitis with another word that we. So this is why this became the medical term of the week, because I was like, oh, that's a word, and then it's got another word that I need to then define. It's like I always take these difficult ones where I'm like, I got to figure out this thing and learn it for myself.
Read and learn things.
So the peritoneum is the lining inside the abdominal cavity, right? Like it's the lining on the inside of the abdominal cavity. It's the lining outside of the organs themselves. So there's multiple parts of the peritoneum, and they have different classifications. So there's the parietal peritoneum. That's the one that lines the parietal cavity. So it's like inside your abdomen. There is, once you get through the skin into the cavity itself, on the inside of that is a lining. That lining is the peritoneum. That lining is sensitive to pain, pressure, temperature. Because it's on the skin, it has some sensitivity to it that will that benefits having some sensation, right? And if there's a problem with that lining, with that parietal peritoneum, usually it has a sharp pain. And this is important to know because there's another peritoneum. There's visceral peritoneum.
Oh, visceral.
And visceral peritoneum is the lining that goes around the outside of the abdominal organs themselves. So in between these two peritoneums is a space, a cavity, if you will. And we'll get to that in a second. But so there's the parietal peritoneum. There's the visceral peritoneum. The visceral peritoneum covers the organs. It's less sensitive to touch and pain. So when you have a problem with the organs or the peritoneum around the organs, it's very nondescript. It's duller. It's vague. It's kind of like, oh, my tummy hurts. Like, it's just like, I feel like I've just been kind of like everything feels crampy and uncomfortable in the stomach. It's kind of like you can't really describe it, right? But early abdominal conditions, things that we'll talk about later in this episode, often cause visceral pain, that kind of dull, aching pain before it becomes something else, right? And then you have, between those two peritoneums, you have the peritoneal cavity. So it's kind of weird to think of it as a cavity because there's not a lot of like, what we think of as space.
Right.
But it's the layer, it's the emptiness between these two things, which are often rubbing against each other. And there's this like lubricating fluid inside of this space so that the viscera and the parietal peritoneum and the visceral peritoneum, they slide up against each other because they're constantly moving. Your body moves, your organs move around, they contract, they do all types of things. But it needs to be lubricated so that things aren't getting bound up so that they can move. Basically they have to do all that during digestion. And then the infection, an infection in the blood in this space can lead to peritonitis. So all of those things, whether it's the parietal peritoneum, visceral peritoneum, or the peritoneal cavity, can all have something that goes wrong with them that causes peritonitis.
Sure.
Now, what could cause it? There's a few different causes. There's a whole list of things, but really the thing to remember is that like peritonitis isn't necessarily it's not a definitive diagnosis. It's kind of like some of the other things that we've talked. It's a symptom. It's a sign that could be from something else, but it is an inflammation of a very particular space, but it's caused by some other things that could be the root cause, right? So a ruptured appendix, with that thing bursting and spilling stuff out into the abdominal cavity, that can lead to an infection of the parietal space, and that causes peritonitis. You could have a perforated ulcer, like a hole in the stomach. So a lot of this comes from holes in other things. So a hole in the appendix, a bursted appendix, that can lead to peritonitis. A perforated ulcer, a hole in the stomach can lead to it. Or something that comes from an injury, abdominal trauma, that can lead to peritonitis as well. And sometimes when we do things like voluntary or even necessary, but like, surgeries that are, I guess, in a way, trauma.
Oh, yeah, 100%.
Like, I mean, really, at the end of the day, it's doing this. You're cutting it. You're doing it in the gentlest way possible, but you're creating spaces and possibilities for infection or injury within the organ, so that abdominal surgeries can lead to peritonitis as well. And then, what do we look out for? Pain.
Yeah.
It's the big one, and we're going to hear it so many times tonight when we're talking about abdominal emergencies. Pain is like the biggest indicator of these types of things. So severe abdominal pain can be a sign of peritonitis. A rigid or board-like abdomen, like that, like something that's like not necessarily like somebody tensing, like the muscles are being tense, but something on the inside of that feeling rigid and distended. That is a sign of peritonitis. Rebound tenderness. What would rebound tenderness be?
So often it's associated with a ruptured appendix. So when we are palpating the abdomen, we'll place pressure on places in the abdomen with the appendix, right? The lower right quadrant. And when it's not so much that there is pain upon the initial press,
but on the release.
Okay. And oftentimes it is very painful.
Yeah.
So that is one of the key signs of an appendicitis.
Yeah. So rebound tenderness, so pain on the release of palpation, or pain that worsens with palpation. That's another sign of peritonitis. Obviously one that's closely associated with a lot of abdominal problems in general, nausea and vomiting, which, as you guys have been following along, anybody who's like going through this journey with us as an EMT is probably the one on this list that is the most important not from a diagnosis standpoint, but from an EMT standpoint,
Yep.
that's the one that we have to look out for the most, because it's the one that can cause the most immediate life-threatening problem, and that is messing with an airway.
Yep.
Yeah.
So nausea and vomiting, that's a big one. Fever, obviously something that we have to keep an eye out for, because abdominal emergencies can also be closely related to like sepsis.
Sure.
Like the pain can be a symptom of that, or the infections themselves that are from abdominal emergencies can develop into sepsis, like the body going haywire. We talked about that in a previous episode. And then, a really bad, sign of peritonitis and these other abdominal trauma or abdominal emergencies is shock,
Yeah.
which is lack of perfusion, right? Yeah. So those things getting so bad that eventually the body starts shutting down. And it's, these abdominal emergencies can lead to very life-threatening conditions.
Right.
So it's important to see them for what they are and to get them to the hospital quickly and not wait.
Right.
It's not we'll just see how that pain progresses in the stomach. It's like, no, if you're concerned enough that it is something that serious, you should go now
Yep.
and get to a higher level of care. So peritonitis is life-threatening. It is an abdominal emergency, and it's a strong indicator of an underlying surgical problem.
Right.
And a patient with peritonitis can deteriorate very quickly. They can start decompensating. They can start having those signs of shock, right? And that's where patients start getting worse very quick. And they are at much higher risk of sepsis. So bottom line, a rigid abdomen with a severe pain should always raise concerns for peritonitis, and don't ever treat it as a, let's wait and see.
Right.
Get them to the hospital. So that's the term for the week, is peritonitis.
It's a good term.
Yeah, I mean, it's a key term because it'll come up in some of the other things.
And I mean, anything that we obviously can't intervene with that's on top of that in any way life-threatening has to be dealt with quickly.
Yeah.
Because, I mean, you don't have an ability to help with it.
Yeah. Diesel therapy, man.
Exactly.
It's really
lights and sirens.
I know it's a trope that, but it's what we have. Like, we're not necessarily giving them a treatment, but advocating for them to move now, to get to higher levels of care. That is the treatment, right?
Yeah.
But yeah, so that's the start of abdominal emergencies. So what do we got going on? What are some other, what are some other abdominal emergencies?
So you've got things like gastrointestinal bleeding.
Yeah, that could be
right.
bad too,
Yeah.
right?
You've got the dreaded AAA.
Ooh, yeah, we're gonna have to talk about that one. That's the one where they come with the car and the jumper cables.
Yep. And they help you get your tire off. Yeah, that kind of stuff.
The dreaded AAA. They just won't leave me alone. Honestly, they keep sending me things in the mail.
Why do I keep on getting the mail from them?
I love things that are obviously not what we're talking about. Like, it's like the first time I was reading through the book and I saw AAA, I'm like, wait, what? That's obviously a abdominal aortic aneurysm.
Yep.
Probably the scariest thing I could possibly imagine.
I mean, it's just your main artery in your chest tearing. I mean, it's no big deal.
The main trunk of your body,
Yeah, you're fine.
delivering blood to the entire part of your.
I mean, you have that whole sac there to collect all that blood in. It'll be good.
Yeah,
it'll be fine.
Yeah, exactly.
Oh, we've got ectopic pregnancies. Those are life-threatening emergencies.
Yeah, absolutely.
Babies in the wrong places.
Yes.
Yeah.
But like we have, I think it might break down into a couple of categories too, right? Like, so some of those are immediately life-threatening, like the abdominal aortic aneurysm, the ectopic pregnancy can be immediately life-threatening, right? Actually, a lot of them can be.
Sure. And the common thread on the three that we just mentioned are bleeding, hemorrhage.
Yep. Yep.
That's the big concern with these. So
Because you don't see it.
Yeah.
Yeah.
But are there some that aren't as life-threatening? That's the question.
Sure. Yeah. So renal colic, gastritis, right? Just kind of a
renal colic. That's the pain you get from a kidney stone, right?
yeah.
Yeah, I would consider that to be absolutely life-threatening. Like if not for the person with it, for anyone around them.
Yes.
Because that is the worst pain you could possibly imagine.
Those folks, every single person I've seen with kidney stones, they just writhe in pain. They are so uncomfortable, and it's one of those times
Whine.
where as a paramedic, I'm glad that I can help them.
Yeah, give some pain medicine.
Give them some pain medicine, maybe give them some, antiemetics, and just get them where they need to go.
Yeah, I mean, that's a really good example of something that's like everybody has heard of the age-old comparison between what's worse, kidney stones or childbirth, right? Like I obviously can't talk I don't know what childbirth is like.
Kidney stones are much worse.
But a lot of people who have experienced both often say kidney stones are worse.
Yes.
And I can vouch that it was the worst thing I've ever had to go through, but it is a prime example of something that is incredibly severely painful, that will rock a person's life, but you can live with that for a few days.
Yeah, you'll be fine.
Like it's not as big of an emergency as an aortic aneurysm.
No.
Like, because that requires immediate surgery. Gastritis.
Yeah.
Super painful. Like
those folks are uncomfortable as well.
Yeah.
And that's kind of the through line with any abdominal pain is it's highly uncomfortable. It's, these people are not, they don't want to be jostled around. They just want relief.
Mm-hmm. Yeah.
So.
And again, like we mentioned before, the common theme amongst all of these things is pain. It's we're living in pain this week. Like it sucks. Abdominal pain is just terrible. I feel so bad for anybody because it's just agony, right?
So we got some things to talk about as far as like as EMTs, as EMS providers. What are our roles in this abdominal emergency?
Well, the biggest one being using our eyes, and our ears,
right?
Like finding stuff out,
Yeah.
right? Like being that. I mean, we've talked about this before, like the frontline investigator, if you will.
Sure.
Like, we're not affecting change, but we're there and we can help collect information for the continuum of care. I think that's the biggest one.
Yeah.
But I guess the question is, like, are we really figuring it out there? Are we finding the answer?
No, I mean, abdominal pain, unless there's a very obvious sign that points to one of the conditions we're going to talk about and a couple that we've already talked about, it's so generalized of a symptom, right? That we're just not going to be able to figure out exactly what's going on with these folks,
right?
We can make a good guess based on our assessment, but it's not one of those instances where we, don't stay on scene if you don't have to for any longer than you have to. These folks are uncomfortable. Just get them to the hospital.
Yeah, I think in my head the scenario where the EMT becomes most valuable in this, or even the paramedic in this space, because there's other than pain meds, like is there really anything you could do for abdominal emergencies?
They need some scans and some blood work, and we can't really do any of that in the field.
It's helping with finding those red flags, like for instance, the I don't mean to skip ahead, but like one of the ones that we'll talk about later is the AAA, the abdominal aortic aneurysm, where it has some very specific tendencies.
Sure.
Like where somebody's like, oh, it feels like it's tearing inside me, right? Like that's a typical red flag for that particular condition, where it's like, if they feel like they're being torn apart, like if there's something deep inside their chest that's ripping, those are the things where you're like, get them in the ambulance, get them right now. But the value is being able to tell the hospital, hey, they gave me this information that they felt this, which made me suspect or be aware of a possible aortic aneurysm.
Yeah.
Because you can hand them that information right away and save them the time of asking the patient, well, what does it feel like? What is this thing? Putting them into a normal emergency room bed versus them possibly having the ability to roll that person straight up into a cath lab or, into a higher level of care that is even more specifically related to that emergency, or prime them to be able to kind of fast track them for that treatment.
Right.
Because I'm not saying like, it's not like stroke where there's like a protocol where it's like you call a stroke alert and they go in, but giving them the heads up like, hey, you may want to double check me on this, but I have a suspicion of an aortic aneurysm. And they can hone in right on that and then double check the work right away to be like, oh yeah, that's a good gut reaction. Let's get them. Let's double check that first before we start moving into everything else.
Sure. And so on the EMT side of the house, our biggest things are supportive care, managing all the things that we are typically managing, airway, breathing, circulation.
Those old chestnuts.
Yeah, providing oxygen as needed. Just patient positioning, a position of comfort.
Yep.
And again, like I said, these folks don't want or need to be jostled around. So just being mindful of that, and then even being mindful when, maybe you're not going lights and sirens to the hospital, but being mindful of the route you take and
lots of railroad tracks.
Yeah, just avoiding unnecessary bumps and jostles and all sorts of stuff like that.
You drove here, right?
Oh, yeah.
You know what Pennsylvania is like.
I
right?
know, and sometimes it can't be helped, but
rumble strips.
Oh my
Nothing
God.
but rumble strips the entire way.
Side note, I totally did not like. It was always like a joke. People talking about the state of the roads in Pennsylvania when I was growing up in New Jersey. And I've been here for 5 years, and it's not a joke. Like, it's just literally life. Like, just potholes for days. Like, I live in a town where we have a particularly rough, like, it's a small, like, little, like a little downtown, right? And, like, the main street that rolls through town is tore up, like, rough. And like, I feel so bad because we've had a couple of patients that we've had to like just do the short transport through town where it's like, one lady had a broken hip and she go. It was like, oh, there's nothing we can do.
There was a guy on Saturday night. He had the head laceration. His head kept on bouncing against the headrest of the gurney. And he's like, why are you so tense? It's like, he's hitting his head on the back of the gurney. That's why he's so tense. He's trying to hold his head off of it so it's not banging against the gurney.
But that's a good point too. Like, that's something that we can also be there to help give care of like, well, can we add a blanket or like,
padding void spaces.
Which is a small comfort, but it means everything.
I mean, they're already stressed out and they're already in a horrible place. So I think those little things can make all the difference.
They often do. And it's, whether folks want to acknowledge it or not, this business is about customer service.
Yeah.
And those little things, like you're saying, Max, they do make all the difference in somebody's experience. I mean, they're already having a bad day.
They're already having their worst day.
Yeah.
If they're in the back of an ambulance, you can be pretty rest assured that it's their worst day in a while.
Yeah.
If ever. So whatever little things you can do to help them.
Yeah. The little stuff matters. It really does. I've noticed that even, having a conversation with them, like trying to get them to smile or like just acknowledging that, like, not having this ride all the way to the hospital in silence where you're like, oh, I don't know what else to ask this person about. Like, worst comes to worst, I've relied on, like, if there's any value I can bring to the back of an ambulance,
sure.
I've realized that I can try to engage with somebody with conversation, even if it's small talk or just things that I can show some general interest in. It makes somebody's day better.
I think right now, like me being in the back of that ambulance, besides like helping them with what they need, like that's my job. My job is to let the medic do what the medic is going to do, and in the meantime, I start asking them questions. If it's a kid, like what video games do you like playing? What's your favorite, subject in school? Or if we had an elderly lady, and I was like, oh, so do you live on your own? What's your favorite TV show you were watching when we showed up? Like just little things to keep them looking at me, not paying attention to what the medic is doing, and not thinking about where they're going or what's going on with them.
My favorite subject in school was lunch.
I'm sure it was. I'm sure it was.
Me too. I liked recess.
So, Max, let's talk a little bit about some anatomy of the abdomen.
Yes, let's quiz Max.
Oh, no.
Ready?
So tell us a little bit
And
about
fail.
Yeah, tell us a little bit about what's going on in the different quadrants. Right?
So we have quadrants. So the abdominal area is broken up into 4 different quadrants. So we have the right upper quadrant, which is, obviously when you're looking at the patient, it's
Sure.
it's your right upper quadrant that you're looking at, right?
No.
No. It's their right upper
Yeah,
quadrant.
everything's patient oriented.
Yeah.
Right?
Yeah. So one of the things that we learned that helped me as far as like the generalization was labs.
Yeah, the LABS.
So right upper quadrant is liver, but there's also the gallbladder and parts of the colon, so that's something that I did not understand going in any way, shape, or form. When I was in school, you had the large and the small intestine, and the colon was that bit at the end. And the first time they showed anatomy for us, it's like, well, wait, that's the colon, and that's the colon, and wait, there's more of the colon.
Right.
So and where's the large and small intestine?
Well, the small intestine's still the small intestine, but the large intestine is also referred to as the colon.
Yeah. So that was something I was unfamiliar with. And then we have
I have a friend who had diverticulitis. So part of his colon got cut out, and now he has a semicolon.
Dad joke.
Man.
Did you like that one? Did you laugh out loud on your ride to work? Let us know.
It's true, though. He does have a semicolon.
Dad jokes will continue until morale improves.
Yes. There's going to be lots of them, people. There's going to be lots of them. And then we have the right lower, which has the appendix is the major thing. And that we were just talking about, the pain response and appendicitis being one of those things that you key on. And then also parts of the large and small bowel. Again, how is that different from the colon?
It's not,
or is it just more of the colon?
It's like the bowel, the gastro tract, right? It fills all 4 of those in some way, shape, or form.
I like the way I learned it when I was in school. I'm sure it was wrong, but I'm sticking with it. And then you have left lower, which is, again, small part of small and large bowel, but left lower is also
A. Oh, no, so it's B.
B.
Is the bladder.
Bladder. Thank you.
Although the bladder is pretty midline. I don't like, that's the one where I'm like, it's not really accurate because the bladder is like pretty much straight midline in the body. Like,
but is it because of referred pain from the bladder?
Could be, but and they also need something to put in the acronym.
Gotcha.
So.
Yeah. So listen, this doesn't have anything to do with anything you're ever going to learn, but we needed something to put here. So we're putting B for bladder. And then the one that really is scary to me, because the left upper has a bunch of stuff that's important and a bunch of stuff that bleeds.
Right.
So you have the stomach, the spleen, which no, I don't want to ever have anything to do with a bag of blood. Yeah. And then you have the pancreas. And also, surprise, surprise, parts of the colon.
And the liver.
And the liver.
Like the liver goes almost all the way across the abdomen. So like it's not typically associated with that part, but there's some of the liver on that side of the body too. Right, so like that left upper is like prime central for bad shit.
And if you didn't know, like, so if you're in a car wreck and something goes into your stomach, there's always something that it can catch as bad news. Yeah. Like, there's no real like clear like area for it to stab through.
Yeah. We see a lot of spleen and liver injuries with seat belts.
Yep.
If you've got a patient that is like otherwise uninjured, but they start developing like bruising across their abdomen from the seatbelt, you should be very suspicious of a liver laceration, or
Yeah, but they grow back.
Spleen. Well, but
does it happen before you get to the hospital?
The problem is that they might bleed to death. we don't want to mess around with those folks. Yeah.
Right. Now, the spleen is responsible for white blood cell production. Is that what it is?
Oh,
you put me on the spot.
Yeah, I'm asking our resident medic.
Oh no! Well, one of the primary things that we learned in school that the spleen is responsible for is to be a repository for, I believe it's red blood cells.
Red blood cells?
Yeah, it's a repository for blood.
Right. Like it's a bag of blood.
It's reserve blood that is in, so when it breaks and it has a problem, it is a severe bleeding problem.
Yes.
But the interesting thing about all of this stuff. And to tie it back into what we've kind of talked about already is like all of those things are in the peritoneal space.
Right.
Like that's the abdomen, right? Like everything we talked about when we set this thing up is like all of those things, they're all covered in visceral peritoneum, right? And then the wall that they all sit in is the parietal peritoneum. So like all of it is interrelated, right?
It's all bad.
Right. And so like if there's a problem with any of those things, it can lead to peritonitis,
Right.
right? Which is the very severe condition. Now, to add to that, there's another while labs is good, it helps us remember like, you know, certain anatomy, and when we're palpating, we know what things we might be feeling which quadrant. There's another set of organs that are not very easily accessible from the front.
Right.
And that's the kidneys,
Yep.
which are huge, right? Like, you know, I'm obviously very fond or not fond of very sensitive to the kidneys because I had kidney stones at one point. Those, like, I'm always aware of them. And like that pain and that area is in the back, right? It's behind all the other stuff. So they call that, while it's not in one of those quadrants, technically they're in like the upper right and upper left quadrants, but they're behind everything. So the term for that space is the retroperitoneal space.
So behind the peritoneal.
Yeah, behind the peritoneum is the kidneys, and the pancreas is back there too, and that's where the aorta is as well. Like, because that's basically right behind your spine, or nestled next to your spine. But like anatomy wise, all that stuff is just gelling,
hanging out.
all in there.
Yeah.
You would have thought they would have designed it better. Like there should be like some defined spaces.
Yeah.
Some breaks. Like, okay, this is your little playground, and this is your little playground. We don't need to be sloshing against each other.
Yeah. As we learn more of the anatomy, the intricacies, and the especially the asymmetry of the body. Like I always thought that like everything you got on the left, you got on the right.
Right.
Oh,
And it's
man.
like, no, like that's not true at all. Like there are complete like organ systems that only exist on one side of the body or the other.
Yeah, and then half the population grows a human in there.
Yeah. And then like even things that we think of as like the heart, technically the heart is not symmetrical.
Okay.
Like it's turned sideways in the chest.
Right.
And then like to make room for that, one of the lungs is slightly smaller than the other with like less lobes. And you're like, I didn't know any of this stuff before. Like you start understanding how all of this stuff is like just so connected. It's pretty cool, but also really intimidating to learn all this stuff.
Whatever you do, don't do anything bad in any of those spots, and you'll be fine.
Sure. Yeah. Don't ever get sick.
Right. Don't get sick.
Or have an
Right. Don't fall. Don't do anything. Just surround yourself in bubble wrap and go about your life, and you'll be fine.
Now, Max, do you remember the difference between something like the spleen or the liver versus something like the organ that you're so fascinated with, the colon or the small intestine?
Yes. So this is actually something that one of the few little pieces of information I had going into this.
Okay.
Because I know there's such a thing as a solid organ and a hollow organ.
Yes.
I did know that.
Yeah.
I went in with that. I just still am rebelling against the thing that it's all. No, it's not the colon that goes down there. It's not over here. It's not back here. It's not wrapped around there.
But we have,
yes.
It's important to know the difference between them.
One bleeds a lot.
Yep.
One can tear or explode or burst.
Sure.
And either way it bleeds, but it's the solid ones that bleed profusely.
Right. The solid ones, when they get damaged or hurt, tend to be a bigger problem because they don't have squishiness.
Right.
Like, this is how my brain thinks of it. Like the stomach, the small intestine, large intestine, those are all, or the bladder.
Right.
They're all squishy. They have hollow stuff on the inside. So
I think of it as they're sneaky. Like the solid ones are like in your face, like, hey, you're gonna die now. The other ones are sneaky. They take their time. They kind of sneak up on you with the problems. That's what I'm going with anyway.
we could go with that, sure. It's not how I was thinking about it, but like once, like there's just like, you know, one can take more damage than the other
sure.
without catastrophically bleeding out. I guess being more sneaky.
So, Mike, tell us a couple of the hollow organs and then the solid organs.
So the hollow organs, things like the stomach, the bladder, the small intestine, large intestine, things that contain other stuff.
Yeah,
right.
Gallbladder.
The gallbladder, yeah, because it is also a bladder. Somebody threw that at me the other day. I'm like, they're like, both bladders are in the lower left. I'm like,
Yeah.
there's only one bladder. So like, there's multiple bladders. There's two bladders. I'm like, what? Yeah, there's a gallbladder. I'm like, oh yeah, it's got the word bladder in it, doesn't it? I was like, oh, I guess it is a bladder. Like my brain, I just always viewed that as a thing. But it's a bladder that holds gall.
Is it gall or bile?
Well, bile, yeah, but
it the same thing?
Yeah, it's gallbladder, right? So those are the hollow ones, and then the solid ones are the ones that, have kind of more solid structure that are meant for creating or filtering other things. So, like the liver is a solid organ. The pancreas is a solid organ. The kidneys, the spleen. Are solid organs. So things that like when they get bashed, they bruise or they tear and they don't bleed. Have, they don't have give. So they bleed.
Yeah. And so one of the big things between the solid, which, you can get an infection anywhere, but one of the major concerns between a rupture of a hollow organ and, a traumatic injury of a solid organ, right? You get a rupture and you can spill those contents from those hollow organs, causing infection,
right?
And then you can have, that trauma on those solid organs can cause heavy bleeding, and ultimately shock and ultimately death.
Yeah, all bad when you injure stuff in there. Some stuff faster than others, but yeah, they all kind of work in slightly different ways. And when you do get trauma or disease or illness and conditions that are causing these things, we talked about it before, the common theme of all these is pain.
Yep.
Right. So, and there's different types of pain. We talked about some. There's the visceral pain. That's very dull, diffuse. It comes from everywhere.
Right.
It's like, oh, my entire, abdomen just sucks. Like
you can't pinpoint it.
Everything is terrible. And if you ask somebody to kind of point to where's the pain hurt, they would kind of do one of these motions where they're like rubbing their tummy. Like it's like everywhere.
Right.
Whereas what we talked about before, the parietal, sometimes called somatic pain, that is the precise. Like it has a more sharp, localized, I think is the proper term.
It hurts right there.
And they point to here, like their upper left quadrant. That's where it is. That's the pain right there, which could be a bit more telling as to where the problem is lying. And it could be worse when they do other things like cough. Those are kind of some things, but there is one other type of pain that we learned about, which is terrible. Like I'm like, why is this even a thing? And that is referred pain.
Damn nerves.
Right.
Damn them.
Yeah. I mean, this is one of those things where, appendicitis is a good example of it. And I didn't know this until we went into the class, but, most often we think of appendicitis as something that's like, oh, I'm having sharp pain in my lower right quadrant, right? Like that is the quintessential form of like, watch out, it's an appendix burst. But sometimes that pain will be masked and not present as the typical type of pain, and it will come up as a stiff neck on the right side.
Which I never would have even guessed before getting into all this.
Right.
Like, that can't be it. It's right there. Look, I can point to it. It's right there.
It's not a radiating pain. It's not like, oh, that pain starts somewhere and seems to hurt everything on that side moving out. Kind of like what we think of with like a with a heart attack where it's like, oh, I'm having a pain that radiates out to my jaw. It's not really like, oh, I have a pain in my chest and then a pain in my toe. That's a referred pain. But a radiating pain is something that you feel is in one spot and then moving somewhere else and you can feel it the whole way. So like the referred pain is something that's like almost completely unrelated to the pain that you're currently having. It's nuts.
No, it is. I mean, and before this, I would say like, well, dude, like take some Advil and put some ice on your neck. I guess I don't know what to tell you.
Yeah, but it's because of nerves.
Yeah,
basically, the pain is felt somewhere else because of a distant site with a similar nerve supply.
Right.
So that's why a good example, like we mentioned before with the appendix, is something like gallbladder. Gallbladder pain can often present with like right shoulder or back pain.
Yeah.
Because the nerves move.
Gallbladder pain all this time.
Yeah.
It hasn't been my back. It's been my damn gallbladder.
But
I must have pulled it.
Those are the things that you can look at. Like if you see other patterns, like going like, man, every time I eat fatty food, my back hurts. Well, that might be an abdominal emergency, not necessarily just hurting your back.
Right.
Lower back pain and AAA,
Yeah.
aortic aneurysm.
Yeah.
Yeah.
So, if you see those things happening, you can help put the pieces together. Right.
Next time I'm in class and I throw my back out, I'm going to say, "Oh my God, my aorta!"
You're about to be really popular.
But yeah, so what are we looking for? Like we've talked about the signs that we should see when we get there, like the red flags, right? But how are we looking for them when we get there? That's our job, right?
Right. Well, things coming out of you that shouldn't be.
Yeah.
That's a big one.
Kind of starts with your scene size up, right? Vomit.
Yeah, obviously that's, I'm having some sort of problem with the stomach area, right? Like, pain in the abdomen or other type of abdominal problems are going to cause the vomit. You feel generally nauseous. Right. It's going to cause vomit, right?
Well, and on the, literally on the other end of that, there is, the dark tarry stools. Or,
we've heard it's a particular smell.
It's not a good one. No, it's not a good one. And once you smell it, you won't forget it.
Blood.
Yeah, blood.
Particularly in either one of those locations, like blood in vomit or blood in stool.
Right.
And like the different types of, like if you have so you get coffee ground emesis. That's like digested blood that's being brought up through vomit, right? So that means that it's a lower GI. It's in the stomach area, but that could be a GI bleed that's causing like it to come up. But there's a difference. So you're looking out for things that like coffee ground looking material that's digested blood versus bright red blood. Those are two different things that you should note in what you're seeing. Right.
Yeah.
So not just the presence of blood, but what the blood looks like within that thing. So same thing with like stool. Right. So dark, tarry, black stool is like digested blood, which could be indicative of a bleed higher up in the tract versus bright red blood, which could be something that's more lower related, like hemorrhoids or something like that, where it's like, the blood's being introduced right at the end instead of higher up in the abdomen.
Literally at the end.
Yeah, right at the end. Right at the end. So like we're looking for that. What else?
So medications that somebody might be taking
for antibiotics.
Yeah, maybe. Antibiotics. Maybe Imodium. Yeah. Maybe an antiemetic that they have.
Yep. Something to treat the like some nausea, right? Yeah. Like that's the antiemetic. What about trauma?
Yeah.
Oof. Yeah, motor vehicle.
Yeah, I mean like abdominal trauma, like bruising. I think that's the big one, right? Like, okay, yes, the illness side is tricky, right? Like we're looking things on the back end, right? Like, on the back end. But so that may be that's the sneakier side of things, right? There's not this outward appearance of things that could be going wrong, but trauma at least gives us some indicators of like, oh, they've got a lot of bruising and like, marks on their body. Hey, maybe they have some problems with their internal organs.
Like seatbelt sign.
Seatbelt sign. Yep. That's a good one. Or any of those types of like, signs of internal bleeding could be like that big bruising and just discoloration and the distended bellies and all that stuff. Like if it is trauma related, we definitely want to consider, like with all trauma, the mechanism of injury.
Yeah.
Like, how did things happen? Is it more likely that someone's going to have, like if it's something that's like an amputation, well, maybe that's not going to cause as much of an abdominal injury as something like a motor vehicle accident or a fall. Like those are the things where it's like blunt force trauma is probably, or even penetrating trauma too, where it's like, oh, that could cause nicks and tears, and what we talked, like the peritonitis can be caused from ruptures or holes in other organs, right? So like there's things we should be looking for as soon as we get there.
Yep.
What about the general impression or like the kind of primary assessment?
When I show up on a scene and I see somebody that is just, again, writhing, they're uncomfortable, they are trying to, they're moving around a bunch and they're trying a bunch of different positions to sit in to just try and find some level of comfort, that lets me know something.
Yeah.
And they will squirm and squirm and squirm until they get some sort of relief.
Yeah, writhing, I think, is a good way to explain it.
It's going to be very obvious that they're in distress, and a lot of times we'll see diaphoresis. They'll be real sweaty.
Yeah,
they might be pale.
Like the circulation, like essentially, we're talking about signs of like shock, right?
Yep.
Like
some other things. If we've got hepatic or liver involvement. That we may see some jaundice on somebody,
which could be yellowing of the skin and eyes, right?
So, there's also we do have to be concerned about the airway, right? Especially if we've got nausea, vomiting. But oftentimes these people are breathing really fast because they're in pain, right? Their heart rate's up, they're breathing really fast, just because they're uncomfortable.
Yep. I think like obviously that's signs of distress, right? Like pain is going to increase respiratory rate, heart rate, blood pressure. Usually those are going to be rising together because they're responding to pain, but also the things of like the opposite side where like drops in blood pressure. So like late stage signs of sepsis, for instance, like that is a condition that can be caused by the abdominal emergency, like a inflammation or a infection stemming from one of those other things. And then a late stage sign is like, oh man, their pressure's starting to drop, and all of a sudden they're getting terrible perfusion, and you're seeing shock and that cool clammy skin. It's like, oh, they don't look good. Like they look bad.
Yeah, and especially if they've got some sort of hemorrhage going on, regardless of the cause, right? At some stage, we're going to get an altered mental status. Or, if they've got that sepsis starting, they're going to have an altered mental status.
Yep. AMS.
So
it's almost like everything that we've been learning week to week ties in together.
They're connected to each other? What are you trying to say?
Oh man,
that it's one big puzzle that we're trying to solve.
It's not easy, and you
Come
just
on.
react to one thing at a time. You have to understand a whole bunch of it, all interacting with each other.
Yeah.
Oh no, I'm out.
I've seen TV. They drive them real fast. They get them where they're going, and then they say clear a bunch.
Right.
And then at the end, they start punching them in the chest, and they pop up, and they're fine.
Yeah.
So, we start to look at gathering history, right? Our OPQRST, our sample, and so when we're talking to these patients, we want to ask them, hey, what was the onset like? Was it sudden? Did
Yeah.
it come on slowly or gradually? Is there anything, what provokes it? Anything that makes it better or worse? Movement, eating, any sort of tenderness upon palpation. As we've talked about, what's the quality of the pain that they're feeling? Is it sharp, dull? Is there a tearing sensation, which is a very bad sign?
Yeah.
Does that pain go anywhere? Right? Does it move as you move? What's the thing? And severity. And I can tell you this right now: if they're very uncomfortable, they're going to tell you it's a 10 out of 10.
Yep.
And you should believe them.
Yeah.
Other thing is time. How long has this been going on? We're trying to establish, a timeline. Have you had something like this happen before?
Yeah. Yeah. And
yeah.
and usually, how does it progress? Like, if you've had it happen, like, is this in line with what you've seen?
Right.
How long has it been going? Right. That's the Oh, I've been miserable for 4 days.
Sure.
Oh.
Ooh.
Well, that's not good.
No.
Yeah.
So, a past history can tell us some things as well.
Yeah.
Did you just have a surgery?
Yeah. Surgeries.
Yep. That's a big one.
Do they have a history of ulcers, gallstones? Have they had a AAA that was repaired before? Right. If they're pregnant, what about ectopic pregnancies? Do they have a history of Crohn's disease? Right. That's a big one. Sometimes what was their last oral intake? So we talked about poisonings and things like that, right? We talked kind of about how food poisoning
Yep.
is that, or that was perhaps that was during infectious diseases. We talked about that because that could be.
I can't. Well, it could be either or, but I think it was.
or.
I think it was poisonings for
Yes.
food
Yeah.
poisonings.
So, could this be something related to something that they brought in orally, something to eat or drink?
Right.
You know,
Could it have come from something they were doing?
Right.
Like obviously we talked about trauma, but
Yep.
even things beyond trauma, you can have severe internal injury from just doing something. Unfortunately, the human body has not evolved out of the ability to injure itself from its own actions.
That's why we're in business, people.
yeah.
Like,
Poor decisions and the human body not able to just be impenetrable.
right. Like, what is it called when you have the abdominal wall that, a quado, what we were talking about before.
A hernia.
Herniation, right?
Yeah.
So like a herniation, a quado. Wait.
Open your mind.
If you guys don't know what we're referring to, you need to watch the original
Total Recall.
Total Recall with
Yes.
Arnold Schwarzenegger. And he goes to Mars. There's this weird Quado character.
Yeah.
Oh my god.
Michael
He's in
Ironside's
charge
in that
of
movie.
every-
Michael Ironsides is the best.
He's awesome.
Yes.
But like a hernia is like, the body, you're trying to do something and it just rips and like your intestines and stuff start spilling out of your body, right?
Right.
So that's evidence of just doing something like lifting can cause trauma, can cause a tear in your
Internal.
in your internal organs,
Yeah.
your external organs, your body. Like, it's crazy how as we age, parts of us get less durable and it could just break, right? Just from use. It's almost like if we get left out in the sun too long, we just,
Dry up like a raisin.
just start breaking apart. But yeah, so I think that's to your point, like asking the questions,
Right.
all of the questions that you can add, you have all the opportunity. When else in the paradigm of patient care does one patient get to have 4, 3, like sometimes, most of the time 2, 3, sometimes even 4 healthcare providers giving them undivided attention?
Right. It's-
Use the time.
They should feel lucky.
Yeah. They usually don't.
No,
I've realized that I don't think
they don't
usually
see it that way.
feel lucky.
No, they don't see it that way at all.
But yeah, so I think there's a lot we can do in the secondary assessment.
Right,
Like the
right.
primary, the secondary, it's our fact-finding time, it's our interview. But what about beyond asking the questions? What are we looking for on the actual body?
Well, then you get into like that physical exam where you're actually getting hands and eyes on.
Yeah, right? Like, what are we doing during that physical exam? Like, and not just the, oh, well, there's like a trauma exam. We're going to look everywhere. At this point, we're probably going to focus, right? Do a focused exam on the abdomen. What are we, like, oh, you have pain? Well, let's dive in a little bit.
We've got the background. We know where it's coming
here.
from. And I guess you're going to start with your eyes and your hands. So you're going to start with inspection, looking for distension, looking for bruising, looking for scars, evisceration, pulsations, like things that aren't normal on the human body. And then there's auscultation. It's a big word with a stethoscope. It's called a stethoscope, and you're going to listen to things like bowel sounds.
But what are we listening for with bowel sounds? Like, so what could that be indicative of?
So I know that the one that sticks in my head is the dripping sound.
Yep. I mean, that they did tell us in class that like bowel sounds can sound like that dripping faucet, right? Like something that sounds like
it's a GI bleed.
Right? No, that's just what bowels are supposed to sound like. They're supposed to have some level of activity, but a lack of that could be a sign of a problem.
Sure.
Right.
I don't know. I don't know if you might know, Jonathan, but like what a sound of a bad bowel might sound like.
Off the top of my head, I couldn't.
I don't know if there is.
So one of the big things is just are bowel sounds present or are they not present?
Right.
That's really kind of our main focus when we're auscultating bowel sounds.
Or listening for things that could be like gas has a particular set. Like, you know, if someone's particularly gassy, or that could have like a sound of like a lot of like internal farts, basically, like, you know, just constantly. So if that could be, it may not be something that's relevant to us, but it could be something that's, you know, something we can relay to other levels of care. It's like, hey, I listened to the bowels, heard a lot of gas, or I heard normal bowel sounds, or I heard none. Like, you know, those could be, obviously we're not diagnosing.
Or if nothing else, just what did you hear, document it so they can have the information.
Exactly. So you're listening for things. But I think the primary one is palpation, right?
Yeah, touching them.
And we can learn a bunch from that. Maybe not definitively, but we can help kind of localize things to a certain area using palpation.
Well, like he was saying with the rebounding pain, like if you've pushed in and the pain is on the rebound of your palpation, then that's going to tell you something specific.
Yeah.
Rebound tenderness is probably the biggest thing that I look for, especially if I've got other things pointing towards like a possible appendicitis.
Yeah.
You got to be really thoughtful when you're palpating, because these people are uncomfortable, like I've said, and you don't want to they may be in a manageable state right now, but if you go start poking around on them, like without some thought, you may worsen their discomfort. And so it's just something that I do, but I'm very, very thoughtful about when I do it and how much pressure I place when I'm palpating.
Yeah.
And the rigidity that's mainly associated with an internal bleed.
Yeah.
Internal bleeding after like a trauma of some kind.
Or it could be like inflammation. Like, so a rigid abdomen, like for peritonitis, doesn't necessarily mean bleeding.
Right.
It just means that that's inflamed.
Okay.
Right. Like it's there. You're feeling for things that can be stiffer than normal because they can be engorged with blood, which is inflammation. Right. So you're looking for things that feel out of place, because normally the stomach feels squishy.
Right.
And if it doesn't feel squishy, that's a sign. Right.
Sure. Pulsating masses. That's one thing we want to mention.
The terrifying find of pushing your fingers into somebody's belly and finding something that's pushing back.
Right. In which case you should
stop
pushing very carefully stop what you're doing and very cautiously and quickly get them to a hospital.
Yeah.
Oh, interesting.
Yeah, let's push harder. Don't poke it.
Poke
it with a stick.
I'm holding pressure.
No, obviously the thing, and we keep harping back to this one because I find it so terrifying, and mainly because my mom almost died from one. But the AAA, the abdominal aortic aneurysm, as you push in on an abdomen, that's an aorta that has grown, right? It's ballooning. It's getting bigger. And obviously the aorta is the main artery leaving the heart.
It's a weakening of that vasculature.
And it's weakening it, and it's getting bigger, and it's going to be pulsating because it is the most pressure that can be coming through the body at any one time. It's what's happening immediately as it leaves the heart. Like it's the descending aorta. So if you're pushing it on an abdomen, you feel like a mass in there that's pulsating with the heartbeat. That's very bad because that thing, if it's large enough for you to touch it, it's probably large enough that it's going to rupture soon, and you need to be very quick with your actions to get them to a higher level of care. Because when that goes, there's no saving.
Yeah.
Like if it starts bleeding, they bleed out into the peritoneal cavity, and that can hold a lot of blood. It holds all the blood.
Yeah. Until all the blood.
Yeah, all of it. Until they don't have a blood pressure anymore.
They don't have it left for anything else.
So those are the things that we're feeling for, that we're keeping an eye out for, red flags in these abdominal emergencies. But we have a list.
We do?
A list of the abdominal emergencies. A bunch we have mentioned already.
We have.
Right.
Yeah, right. So peritonitis was on that list.
Yep.
We went through that. Obviously, it was our medical term of the week. Something that can stem from other abdominal emergencies that kind of lead to that condition, that inflammation in the peritoneum. Appendicitis. The probably the
appendix.
Yeah. The most well-known, I think, in my opinion, abdominal emergency.
I would agree.
Right?
To die from something that is completely useless.
Yeah, we don't need it anymore.
Yeah.
How do you die? From appendicitis, from my appendix bursting, something I didn't need anyway.
Yeah. It's just a ticking time bomb kind of
Like
hanging out.
practically just cut that baby right out of there.
Yeah,
Just
like
get rid of it.
the things we're looking for, like the nausea, vomiting, low-grade fever. Fever we haven't talked about much yet. Temperature, which we're going to get to probably a little later too. We're going to talk about temperatures.
Yes.
But that's a kind of important vital sign with all this stuff too, is getting a temperature
Sure.
to see if they're getting kind of like signs of infections at the same time too.
Yep, sure.
Right. So that's something to definitely keep an eye on for, is that like low-grade fever, loss of appetite, just malaise, right? Like that is the risk of that rupturing is turning into peritonitis and dying. Like
Sure.
you will die.
Bad.
So some other things I'd never heard of, honestly, and I'm not 100% familiar with yet in terms of like exactly what to look out for, but like cholecystitis.
Nice. Well done, sir.
Which is biliary colic. It's related to the gallbladder. It's like the gallbladder being inflamed and having problems with that. I've had friends that have had gallbladders removed. I believe this is what leads to that.
Right.
It's the inflammation or irritation of the gallbladder or the bile ducts. And you get that it's in the same quadrant that we would associate with the liver, the right upper quadrant. And this is the one that's like, it's got a very particular thing to look out for. Like if you eat a bunch of fatty meals and you have severe pain right after fatty meals, that's kind of a good indicator that you're having gallbladder problems. Right. So if it's worse after fatty meals, and we talked about before, the referred pain that has pain radiating to the right shoulder or the back, these are all things that are consistent with cholecystitis.
Sure. Yeah. Then you have pancreatitis, which is inflammation of the pancreas.
Pancreatitis.
Yep.
Yeah. But the pancreas doesn't seem that important.
No. Right. I mean, it's only important for like glucose, insulin production.
Yeah, like the
things like
beatus.
that. Right.
Yeah, the beatus.
That's all.
But like that can that's another thing. Like, what is it with the body and the ability to create stones inside of things?
It's magic. It's magic.
Gallstones, kidney stones, power stones,
Power
earth
stone,
stones, mind stone. No.
They go in the power glove.
The power,
Yeah, exactly.
they go in the Infinity Gauntlet.
Right.
Yeah.
That would be the weirdest superhero gauntlet in history. Is like a gauntlet made out of all of the stones that were made in the kidneys of superheroes.
Yeah.
Like,
ooh, I like it.
this represents the most severe pain of all the superheroes in history.
Superman was a crying baby with his with his
Kryptonite.
gallstones.
Oh my God. Could you imagine what a superhuman or like kidney stone would be? No.
It'd be spiky.
Like like, I bet you that is what kryptonite is. They say it comes from Krypton. No, I think it's actually it's the kidney stone from Superman.
Yes,
Yeah.
exactly.
That is my kryptonite. Tangent.
Green,
Sorry.
jagged.
Yeah, they are not pretty. Pancreatitis. You measures the inflammation of the pancreas, but like it's caused from gallstones. Could be alcohol, medications.
Yeah.
This one, upper abdomen, radiates to the back. So here we're gonna see nausea,
radiation,
vomiting, abdominal tenderness, may appear very ill. Cool. Like that sounds super descript, right?
Can't
Like
you just
all
pick
of
something?
these are so similar.
Yes.
Yeah.
Yeah.
They're nuanced.
Like, listen,
Yeah.
gallbladder. Pick something. Pick something that is going to represent you being sick, so we can figure this out quickly.
Yeah. GI bleeding, that's obviously a big abdominal emergency because like an uncontrolled abdominal bleed or GI bleed can be super bad quick because it's got a lot of places it can bleed out to, and it may be minor, but if it's not, it's going to cause a lot of problems, right? And you have different areas that can have GI bleeds. So you can have upper GI bleeds, lower GI bleeds, and these can have severe problems too, not just in the I'm bleeding out, like the exsanguination side of it, like the hypovolemia, but also like a GI bleed can lead to filling the esophagus and the trachea and like drowning on blood, like generally the worst sounding things ever.
Right.
Yeah.
So like the upper GI is the esophagus, the stomach, the first part of the small intestine, or the lower GI, which is the distal small intestine. That's the lower part. The large intestine, also called the colon, or the rectum. You know, so like you can have bleeding that happens all along that whole thing. But like vomiting blood, is one of the big ones, right? Like and it could be bright red. We talked about this before. It could be bright red, which means that it's less digested, or it could be coffee ground like, where it's more digested. So there is a term for that black tarry stool we were talking about. So the stuff that comes out the other end, melena, is the black tarry stool, or hematochezia,
Hematochezia.
Cheese.
Oof. I would not use that word. Which is the bright red blood in the stools. But like this is very associated with like things that we think of where it's either like anxiety or sometimes even the low blood pressure stuff, because it could mean that like they're bleeding out, right? So weakness, dizziness, signs of shock. Like that's like the drop in blood pressure is the thing that's going to make them go. Ugh.
And man. Quick story time.
Story time
with Jonathan.
So as I finished paramedic school and got my paramedic and was doing my precepting to be released as a provider for my agencies, one of the calls that I walked in on with my paramedic partner was, again, we talked a little bit about the smell. Okay. We got called for somebody that had an altered mental status. Well, we get there, it's like, I can smell this as soon as I just as soon as I open the door. And then as we start looking around, we're in this old apartment building and it's got carpet in it, and there is smeared all over the place the dark tarry stool. I mean, it's everywhere. And as
all the PPE right now.
Yeah, I mean, it's and what you could do, you could trace it all the way from the bathroom all the way back into the back bedroom, and I mean, it's everywhere. And so we get in there, and this guy, he's in shock, right? So he's altered. He's not really able to kind of elaborate what's going on, and I make the decision real fast that we're going to call a helicopter for this guy. So he's in hypovolemic shock, as well as probably being septic. history of liver issues, hepatitis C, like all sorts of stuff, and which added an extra layer of, needing PPE for us,
Right.
to make sure we were safe. But I mean, couldn't get a blood pressure on this guy. He was hypotensive all get out.
Yeah.
Cool, clammy, he looked awful. And ultimately, it came down to the fact that he had a GI bleed that he had been kind of ignoring and dealing with for probably a week. I think the last time we talked to a bystander, and they said they hadn't seen him in a week. So he's just decompensating this entire week, and this is what we walk in and find, and not a good thing. I believe he ended up getting 2 units of blood from the helicopter as they were taking him to a facility.
I can imagine he needed that.
Yes.
Just a very sick guy. So, I mean, GI bleeds aren't anything to play with at all. But very shocky.
Yeah.
As soon as you walk in. So, kind of a thing.
Yeah. Man.
All the PPE right now.
You're talking about all the poop smeared everywhere. I'm like, I'm about to be like, hey, Max,
well,
I'm not going to be in class
so
this week.
The decision was made. It's like, well, what do you do? Do we sit in here and try and assess him? It's like, nah, man, we got to go. We put him on a mega mover, which is, like a draw sheet with handles. And we just got him out of there and got him in the back of the ambulance and started doing all the things there. Because, first of all, he was definitely a load and go patient. And second of all, we did not want to be, it was everywhere.
Yeah.
So we did not want to be in that environment for any longer than we had to.
Right now.
Very sick guy.
Yeah. GI bleeds, they're terrifying too. All this stuff is terrifying. The AAA, that's the other one on here. And we talked about this one a bunch, but again, it's what can you do? It's almost like it's like almost like a brain aneurysm, right? Where it's if it's your time to go, it's your time to go. There's not a lot you can do for a sudden burst aneurysm in your brain.
Yeah.
So it's that's one of those ones where it's you might have a chance. Someone might find it before it turns real bad, but just getting somebody to the hospital is the only answer.
I've had a handful in my career of patients that had AAAs.
Mm-hmm.
And I remember we picked this one lady up, and I say that I live in the city of the stair chair because we use a stair chair constantly. She was in a bottom apartment, but we had to go up the hill.
Yeah.
And so we're having to take her up the hill in a stair chair, and it was a whole ordeal. But she, talking about people writhing in pain, she shocky looking, pale, cool, clammy, could not get comfortable. Every little bump or movement hurt, and hypotensive. And again, these are, all these abdominal issues seem very similar when they're at their extreme. But and it didn't dawn on us until after the call that this is what it ended up being. We got a little bit of a report from the hospital back. She didn't have the pulsatile mass. She didn't have back pain. She just looked awful, looked uncomfortable. And she was a sick lady, man. Again, these folks just, they're not going to be comfortable on the extreme end of things.
Yeah. You have to forgive me because my brain all of a sudden went in a completely different direction while you were talking about, hey, I live in the town of the stair chair. And I immediately went back to our joking around the other day of starting a D&D campaign of EMS. And I'm like, man, wouldn't it be cool to have a +1 stair chair or feather fall?
Yes.
Roll initiative for stair chair use.
It would totally be one of those things where it's I need a magical stair chair. The +2 stair chair of stability. They will not fall out of that thing. And you only need one person to bring it down this. It's
amazing.
Oh man, it's gonna happen. We're gonna build.
We have to.
Yeah. The stair chair would absolutely be one of those mythical items that gets found along the way. But you'd have
everyone you find is cursed and it's twice as heavy as it needs to be.
Or you get cursed with a squeaky tread.
Yes.
It's just constantly. Oh man, this could be a thing. It's gonna be a thing. We're gonna do it. We're gonna do a Dungeons and Dragons. What would it be like? Ambulances and
Oh man,
alarms.
stretchers and staves.
Yeah. Anyway, so hernias. We briefly touched on that. Hernias is one of those things. It's like it doesn't seem as emergent as some of the other ones because people will have hernias for like decades.
I have a story time with hernia.
Do you?
So there was an older guy that used to do installs for us, and he was a very, very overweight guy.
Yeah.
And he had a hernia that was bigger than my fist. That when he first started doing installs for us was just like a subtle impression in his t-shirt. Towards the end, before he finally was fired, it literally was like the entire fist had come out and then started closing around said thingy. So he didn't have any pain from it. He didn't have any apparent complications from it. It was just the most disgusting thing to see because every now and then he'd lift up his arms, his shirt would raise, and you'd see the alien Quado come out and want to say hi.
Open your mind.
Yes, open your mind. Or throw up immediately. One or the other.
Oh man, it's one of those things that a lot of people that work manual labor jobs end up getting because of the lifting. And, and I mean, and they may even be using proper lifting techniques, but it's just that straining and that causes issues.
Yeah. Example of the body breaking while in use.
Yeah.
It's just now I have a hole.
And for his
everything's
case,
gonna
it was
start
just
spilling out.
his extreme weight just apparently had stretched his stomach muscle so thin that it had created gaps.
Yeah. Another one that we learned about in class, which is, it just sounds so terrible.
Not for us.
Well, I mean, no, I mean,
everybody.
I literally
sounds terrible.
can't get.
It's the one that we can't get.
Well, yes, but an ectopic pregnancy is.
But you can run it on an ambulance.
Yeah, it sounds like I just feel so bad because, it's one of those things where it's like you're torn because it's the creation of life, right? And it's this thing that we all come from, like the idea of pregnancy and conception, but like it's literally deadly conception.
Yep.
Like it is a 100% like it is going to kill like the mother.
Yeah.
If this thing progresses, it's just a misplaced like pregnancy. And if like it will kill them, like it's in the wrong spot. It is not like life cannot support it. And it has to be like, you have to get that patient to a hospital as quickly as possible because that can rupture, cause a lot of bleeding. They could die if you don't do it. If you don't go get it taken care of.
And I mean, I don't know, but would that cause the woman not to be able to have a baby again?
Yes. Yeah.
It can, but it doesn't.
Can.
It doesn't
It's not a
necessarily.
guarantee, but it does increase the likelihood of being unable to.
Yeah, I think
conceive later.
I think in extreme cases, it can lead to, like obviously. So an ectopic pregnancy is a pregnancy that implants in the fallopian tube, right?
Right.
So, and that's not, it needs to implant in the uterus. So it means it's implanting way too far up in the reproductive organ, right? Can't live up there. If once it grows, it bursts the fallopian tube apart and it creates like, it'll kill the mother, right? So if it progresses too far, it can lead to a hysterectomy. But I believe, and don't quote me on this because I'm not so up to speed on it, but like I would imagine if you catch that early, if you have scans early or signs of it early, they might be able to perform like some sort of abortion or DNC, I think it's called, like something to end the pregnancy earlier so that it happens before it gets to a traumatic point where it starts injuring other things.
Sure.
I believe that's the case. But if it gets too far, it could get so bad that it leads to like irreversible sterility, really, like by forcing a hysterectomy where they remove the whole uterus.
Right.
And a lot of times, though, somebody that is, how do I want to say, someone that knows that they are pregnant and is going to receive care, that's going to be caught on that assessment, hopefully, at their OBGYN.
Yeah.
But the person that I worry about is the person that doesn't know that they're pregnant.
Right.
Yeah.
And that this has, happened.
Yeah. Or scared and too afraid to get care for it.
Right.
Like the teenager who is too afraid to tell their parents, and they're trying to figure out how to eventually, and they're not going to an OBGYN appointment.
Sure.
Right. Those are like, unfortunately, it's going to probably show up more in patients that do not have access or are not getting care, the early care in the pregnancy phase, or not know about it. Right.
Yeah.
To your point. So, but this, like, the things to look out for here are obviously the lower abdominal pain where the uterus sits, usually one-sided. And it may or may not have signs of, typical pregnancy. It may happen early enough that they have not had a period yet, or they may not have taken a pregnancy test yet. So they may not know,
Right.
but eventually those things are going to be indicative too. Like, if, when was your last menstrual cycle?
Right.
Like, it was like 7 weeks ago. Okay. Well, then that could be a possibility that you're pregnant. Right. Like,
And also, you have the referred pain again, where it's not necessarily something that's specific to the area.
Yep. The referred pain can be something that's showing up. But it's, you're looking for signs of shock, and, ultimately at the end of the day, it's like that is life threatening.
Yeah.
Because if it grows to, like, if that pregnancy grows to a point where it's threatening the rest of the anatomy, it could burst stuff open. It's terrible. Like, it's terrifying. Like, but something to definitely look out for. My favorite one,
It is your
obviously,
favorite one
on the list is renal colic, also known as kidney stones.
Yep.
How was that?
Fuck kidney stones, man. I don't like to curse on the podcast, but I will freely hate on.
I'll
kidney
jump
stones.
in there and say, fuck this.
So, there's certain things it's okay to curse at, like fuck
Did you hear
cancer.
that? I got permission. That was permission.
No,
Using
no.
it wide
Yeah.
range. That whenever I need to curse, I'm just gonna say
You
kidney
use
stones
it
first.
Yeah, I can't stop you from doing it ever anyway, but like that is the worst. You get the severe flank. Have either of you guys had kidney stones? No. Okay. So severe flank pain. Like it feels like someone's like constantly just like jabbing a knife, or like giving you like a Charlie horse in the back, like right lower back, or for me it was on the right hand side. And it progressed to a point. It was actually on Christmas one year. I just felt terrible.
Merry Christmas.
Yeah, Merry Christmas. I made dinner for everybody. I made like a standing rib roast for all of my family, and I was like, oh, I feel terrible. Enjoy the food. I'm gonna go to sleep now. It was like 8:00 at night, and I woke up at like midnight. I'm like, I remember turning to my wife. I was like, you need to take me to the hospital.
Yeah.
Like, I'm like, this is it. You got one last Christmas out of me. I'm circling the drain.
all
Like,
over.
I thought it was the end. man.
Elizabeth, I'm coming home.
Yeah. So, like, I remember laying in the bed in the hospital. I walked in and the nurse was like, "You look terrible." I'm like, I don't like. Please help me. Like, I'm shaking, and they put me in a bed, and I'm just grabbing onto the rails on the side of the hospital bed, just tensing every inch of my body from pain, and nothing helped. Like, nothing relieved it. They came in and gave me morphine at one point. That did nothing.
Yeah.
Actually, I can't say it did nothing. It came in and it was like, I guess I can. It's a little bit better, and then it lasted for like 4 minutes and then went back to a 10.
Just knock me out.
And they're like, well, we can't give you anything else for a while. We have to do like the CT scan. And it's like, I'm like, okay, please just kill me. Like, I'm just like, I'm just like, I was ready to break the arm, like the railing off the side of the bed. Jamie tells a story. She's like, I was scared. She was scared because she's never seen me like that. Like it was absolutely terrible. And then eventually they get the scans back. They're like, oh yeah, you have a kidney stone. I'm like, you probably could have figured that out earlier, but cool. And they came in with Dilaudid.
That's the ticket.
Well, I don't particularly want to experience that stuff, like the opioids, knowing how dangerous they all are. But at that point, I'm like, please, anything to help with this. And I remember them pushing that, and it was a matter of, I'm like, how long will this take? And just finally had relief and immediately went to sleep.
Nice.
I was just, because everything was so exhausted from just writhing that like it hit me, and I was like, oh, thank God.
Yeah.
And just went right to sleep. And like, I remember waking up like an hour or so later, and they're like, okay, you're being discharged now. I'm like, but I don't have this stuff at home. Like, what do I do? What, this is going to come back.
Leaving here.
They gave me a prescription and stuff, but man,
That's a rough time.
Pain. Like, right? Like the common theme of this is pain.
Yep.
Yeah.
And it is like, that one was, yeah, I guess you could maybe say it's more indicative because of where it was. Although it had started, I realize this now, and that for anybody out there, like that referred pain, I had that for weeks leading up to it in my testicle, actually. So I had gone to a urologist because I was having testicle pain and got and went and got checked. It was the first time I ever went to a urologist. It was an ordeal. I got the ultrasound and I'm like, this is really a weird experience. But now actually it doesn't seem so weird to me now, because now I'm we
deal with this kind of
deal
thing.
with people, right? And anatomy. It's not a big deal, but to me, it was. But like, I got exams and all this other stuff. They're like, yeah, I guess you may have like a cyst or something. They saw something on the ultrasound, but it turns out over time, a few weeks later, it was referred pain from an impending kidney stone. Sure. So I got to experience all that. Yay.
He got the full experience.
The full ride, man. So, the abdominal stuff, it's no joke.
It's rough.
It's no joke. But, so that's one of the ones to look out for. And that obviously one of the common things too, amongst all these, the nausea, the vomiting, the general feeling of, abdominal yuck, right? Like it's common. But yeah, so those were all the kind of conditions that we had seen. And the common themes, right? Like the things that we've the recap or the big takeaway from this, we've hit on a lot of it. Things that we need to look out for. We're obviously there for when things go really bad, when these conditions start influencing life-threatening things like the vomit that leads to airway problems, or the circulation, like looking out for circulation problems, and like that person looks like they're in shock, right? Like, so identifying the life threats, rapid transport, and then really being that investigator, that first person on scene to help figure out some things, just so that we can relay information to the higher levels of care, and then help them. And sometimes it may even be convincing somebody that like you need to go, like right now, like you
being their advocate,
helping them, because they may be like, no, I don't really want to go. It's like, listen, why don't we go get checked out, right? Like, you go to a quick trip to the hospital, you go get checked out, just make sure that nothing's that bad.
I have that conversation a lot.
A lot, yeah. But anything else on like things that we should be looking out for?
Well, I mean, we talked about the fact that EMTs can't do a whole lot, but you can. I mean, you can be that calm, reassuring voice. You can be that person that kind of eases them through it. You can treat for shock. It's one of the things that we can definitely help with. Can you fix the problem? No. but you're there to be the hospital's first set of eyes and hands and ears on scene, and then get them the information that they need so they can be treated.
Mm-hmm.
And if it's something serious, get them treated rapidly and correctly.
Yeah. If you could pick like the biggest red flags in your opinion, what would they be? That we've kind of learned over the last
Looks
week.
sick. That whole, like, from across the room, that person looks not well.
That's a big one.
That's a big one. When we start delving into the nitty gritty of the abdominal pain, the rebound tenderness, right lower quadrant rebound tenderness, and then probably the pulsatile mass, or probably the thing I've seen more commonly is that lower back pain with that AAA. Those are some things. Those are probably the three things that, in my mind, are like, man, I'm worried about this person.
Mm-hmm.
So
I would say the in the instances where we're seeing like altered mental status,
that as well.
I mean, that's obviously like a big thing, because it could be a sign of sepsis, and that, like, anything that's like a clear indicator of things progressing to sepsis.
Right.
Those are the big red flags to me. But like distension, like a rigid belly, like that to me is so out of the norm that's like that could be a real like abdominal emergency, right? But yeah, like we've talked about so many. You just have to be aware of them. You have to know. You have to see the trends, and if there's a rapid onset of abdominal pain, it's for a reason.
Yep,
sure.
So, but yeah, so that's abdominal emergencies.
There's only a few things going on.
Yeah, there's
just a couple.
But this leads to a one tool of the trade that Jonathan and I skipped the other day.
We did.
They did.
We saved it for you.
It was a very comprehensive write-up on the subject.
Well, Max decided to leave us a couple episodes ago, and now he's back, and we realized that this would probably be a really good tie-in for the tool of that week, because it was the tool we were going to do for sepsis.
Right.
And being that abdominal emergencies are so closely tied to the idea of sepsis, and it's one of the big watchouts, this tool, I think, is a key one in figuring out if that's relevant.
And we're talking about thermometers, and that's it.
Yeah, we're done.
That's it. I'm just going to completely just gloss over the comprehensive write-up that was done by my co-hosts about the thermometer, and just say, yeah, thermometers, use them.
Okay.
No, thermometers. I mean, it's something that, I don't think there's a person out there that hasn't had a thermometer in their mouth when they were a child, when they were sick. I mean, I think it's one of those assessment tools that everyone's experienced and everyone's had used on them.
Yeah. I mean, I remember being a kid going, how can I make this thing register as
exactly
hot?
If I really concentrate, can I make myself have a fever so I don't have to go to school?
Or taking that thermometer out while mom's not looking and holding it next to a light bulb.
Yeah, 100%.
Kids don't know that nowadays. The light bulbs don't get hot.
No, they don't.
Yeah.
I didn't know that.
Man,
missed opportunity.
So, contrary to popular belief, thermometers have not been widely used in EMS.
Yeah.
So in 1960s and 80s, temperature wasn't routinely taken in the field, and a lot of times they just relied on that hot to the touch impression for the patient.
Every single time I've been on an ambulance and someone's like, "Man, they feel hot," like I'm pretty sure they have a fever, and every time they take a temperature, it's 98.6.
Yeah, exactly.
I'm like, this seems.
It's almost like okay, if this is what you were using for assessing temperature throughout the 60s and 80s, this may answer some questions. And then 90s, you have digital oral and auxiliary thermometers started appearing in ambulances, and you saw the same thing in households. Like, I remember when I was little, you had the mercury-filled thermometer, and then you had the digital ones. And as infectious disease awareness grew with HIV, meningitis, it became even more prevalent to be seen, but still inconsistent. In the 2000s, you had the rise of sepsis protocols and pediatric assessment standards, which pushed an adoption of thermometers into EMS's hands.
Yep.
2010, 2020s, infrared temporal artery scanners and later non-contact forehead thermometers became widespread, which I don't know how are they reliable? Because we had that one that I think we bought at one point. It was a gimmick where you just run it across the forehead and you get this magical answer.
I'm gonna tell you, in general, no. Because every agency that I've ever worked for buys the cheapest thermometer that they can find to check the box.
Of course.
Now, that being said, when I've done clinical time in the hospitals, they usually have pretty decent thermometers, and you can get a decently accurate temperature. It's still a generalization, right? You're not getting a core body temperature from, an oral or a temporal thermometer. But there's something to be said for having them on the ambulance if the right tool is purchased.
Right.
Yeah. And there's another factor too. I know I guess we'll probably get into types of thermometers, but depending on the thermometer, it can be affected by other things going on with the body as well.
Right.
So that affects the accuracy.
Yeah.
And I remember during the whole COVID thing, like doing scouts, like every single check-in, temp,
right.
temp.
Oh yeah, with the IR,
with the IR
laser thermometers.
Suddenly you could find everywhere for like nothing. All of a sudden it was just this widespread thing that you found in every single CVS, Rite Aid for nothing. And so there are different types. There's tympanic.
That's it goes over the temple.
Or the temples.
Right.
So what are the ear thermometers then?
Tympanic versus temporal.
Oh, I'm sorry, tympanic. I'm sorry,
Tympanic
not
versus
temporal
temporal.
So tympanic is the one that goes and measures the temperature at the tympanic membrane in the ear.
Right.
Yeah, right. Sorry.
That's one where you get the kid and you shove it in as hard as you can, and when they scream in pain, you know you're at the right spot.
Or that one that always seems to you can never quite get that little plastic cone cover onto the damn I had that the other day. They handed me the thermometer, get a temperature. I'm like, and I would take that the thermometer out and it would just fall off. I'm like, I'll try that again, and it would fall off. I'm like,
what am I doing wrong?
So I had to take one and then I didn't want to do this with my gloved hand, but I had to push that onto them. Like, well, all right, well, my hand's gloved. So
it seems kind of you would think that automatic on thing would work,
right?
So you didn't have to touch it. The temporal, like you were saying, the forehead going to the temples, digital oral or auxiliary. Axillary, thank you. And I guess that's for the armpits.
Yeah.
And then rectal thermometers. Okay, rectal thermometers are red. Don't use them except for in the rectum, right?
Yeah.
That's what they told us in class. Like if you see the red thermometer, don't put it in your mouth.
In general, yeah, that's the deal.
Are they red? I've never actually.
If you've got the oral or axillary that have the longer probe, have you seen these? They have a coiled pigtail cable that runs to the probe and then back to a digital readout.
No, I know.
Okay. So you can get ones that are color coded and they have a section of the device that is red to indicate that it's a rectal thermometer. Yeah.
So
don't mix those up.
Don't mix those up.
From what I've heard, though, rectal thermometers are, aside from the joke of the fact that it's a rectal thermometer, you got to stick it up a butt to get a good temperature. They seem to be the most accurate.
It is the most accurate temperature.
It's the one that's getting deepest into and closest to the core of the body.
Right.
Correct.
But it's invasive.
It is.
So,
and it's not necessarily in the scope of practice because it's invasive.
Oh, exactly.
Right.
Yeah.
That's the issue.
So, but the digital oral or just oral thermometers seem to be pretty good. The problem is the convenience and time factor in getting it and then having to get patient compliance and holding it. It's not like you have a kid that's hold this under your tongue. So
that is kind of the issue sometimes I have is getting people, or if they're not with it enough or don't have the ability to, they have a hard time holding it in the correct positioning under their tongue. And a lot of the times it will give you a not good reading.
Yeah.
Or if it gives you a reading at all. So it can be some of the issues.
Hence why the temporal or the tympanic are what they are.
Yeah.
Sure.
And it's a quick response. Where I think I know the one that we used to have when my daughter was little it was 30 seconds. to get a reading off of the oral.
Yeah.
Whereas the tympanic, it's like, it's like a matter of like 2 seconds at most.
And one of the ones on here that I'm surprised is not on here actually is the like the IR like the heat gun type ones where it's like, oh, you don't have to have any contact whatsoever.
Nope.
And it reads it off of an infrared thermometer. But like those are there's so many factors that could be going in with that. I can't imagine that they're the most accurate thing, but they're fast.
They are fast.
But I think the theme is there's a lot of different ways to get it, but ultimately, and this is what I've kind of learned, is like nobody seems to trust really any of them.
That's kind of my big thing.
Right.
It's like, okay, I'll get this, but and it's device specific.
Yeah.
It really is. So and it's not even necessarily brand specific or it is like literally individual device specific. I work on some trucks that we've got very accurate thermometers, and I work on other trucks that they don't, like, I would not trust that thing at all. And it's the same brand. It's the same. I can't put a rhyme or reason to it, but yeah, I don't trust them.
So what I've seen is like, even with a multiple thermometers or like, the idea of like, oh, they feel hot or whatever. Most of the time it'll come back and the patient is like within a degree of normal body temp. Mm-hmm. So, to me, it seems like that's a pretty good indicator of like, well, it's close to what a body temp should be.
Right.
It's where you start like getting marginal type things with like, well, it's 2 degrees above normal body temp. Well, is that closer to body temp or is that a low grade fever?
Right.
And that's where I think is the real reason why we should be using these things, especially in abdominal emergencies, what we alluded to before, the idea of sepsis. Like sepsis usually presents with a temperature because it's an infection. Right. And that combined with the red flags and other things, I think we as on the EMS side, the pre-hospital side, have the opportunity to be that first flag, like especially for sepsis, where it's like there is a protocol in place, a system in place that, like, if you see this, if you suspect this, do the alert.
Or the opposite, which is hypothermia. So like you could have the other end of the spectrum.
Yeah.
Where if you're a degree or two too low, now you've got your body feeling in a completely different way.
We all were present.
Yes, we were
at a time where somebody we know ended up becoming hypothermic, right?
And like really close.
And I used an oral thermometer, and they had a temp of 95.2.
Really? Was that low? I didn't know that.
It was very low. Yeah. And so what I knew from that, because of what I know about the limitations of these thermometers, is his core body temperature was probably even like it was probably lower.
Right.
Yeah,
because your head, like if you're getting something off the head isn't really representative of a core body temp at all, because it's completely separated from your core.
Right. So, yeah, I mean, and that's another good use for him, especially in an austere environment, is making a determination on hypothermia.
Right.
Although, if you suspect hypothermia, that one's an easy one. Just make them warmer.
Yeah,
just warm them up as much as you can.
Just set them on fire slowly, and then everything will work out just fine.
No.
Oh, no.
I don't.
What you mean. Okay,
I think that's a whole nother. That's another episode of it involves burn creams and burn dressings and.
But again, like you were saying, they can be limitations. But the main thing, and I think this goes with any assessment tool, if you're getting a wild reading, do it again.
Sure.
Yeah.
Whether it's blood pressure or temperature or SpO2, whatever. If you're getting a really wild reading, do it again.
Yeah. So, I think those are all really, important things to keep in mind, especially, with altered mental status. That's another one where I personally would love to see the use. I would feel like I would want to see myself using a thermometer as well as a blood glucose meter.
Yeah, sure.
Yeah.
Because again, with the sepsis stuff and like figuring out all the things that we can figure out at once based off of the things that we're seeing, like allows us to give the best information.
Yep.
Along the way, right? But yeah. So, but what are there any limitations, Max, to the
So
the
yeah,
thermometers?
so you have cold rooms, hot rooms, sweaty patients. I get the sweaty.
That's the one.
Sweaty would come up with the IR.
Yeah, like all the surface stuff.
or the temporal, same thing.
Yeah,
you know,
like
could be affecting the readings.
all of those are taking the surface temperature of somebody. So like sweat is made to cool someone down. So if they're sweaty at all, you're gonna not get a reading that's indicative of an actual body temp. Right. Or
And
they're wet.
Right.
Yeah.
And they have technique with ear probes. So I mean, it like anything else, there's going to be limitations to them. I really think like the heat stroke victim, the sepsis victim, or the hypothermia victim, those are the ones where they're going to be a huge. To be able to get that reading and get that answer, and to be able to affect change for the patient, that's where it's really going to come in, versus just someone that's not feeling quite right.
Yeah.
Right.
Cool.
So there you go.
So we learned all about thermometers.
Thermometers.
The thermopolize.
And once it's been
Thermometers.
used, don't put the red one in your mouth.
Was it your friend, the thermometer?
It was my dad. Yeah.
Yeah, your dad
He's
calls
like,
them thermometers.
thermometers.
I kind of like that.
I like that. I like that.
Thermometer.
Oh man.
But yeah, cool. Thanks, man.
Thank you guys for doing the excellent write up.
You know, we're all here to share the load, right?
Yeah, right.
All right. So with that, it brings us to our final segment of the episode, and that is the student tip of the week from Mr. Jonathan Aldrich.
So, as we've talked a lot today about
we've talked a lot.
a lot. As we've talked about abdominal pain, it's one of those calls that you're gonna get as a student, as a new EMT, and it's gonna be very generalized as far as presentation potentially. The big thing is, don't dismiss abdominal pain. I want to emphasize that because I've seen a lot of providers write off abdominal pain, and not do as good of an assessment as they should be doing. So we have to still take that seriously. Don't dismiss these people. Dig a little deeper, and because the reality is it could be a true emergency if you don't do a solid assessment. So just make sure you're doing your due diligence and treat it like it's the emergency it could be.
I like it. Yeah. Anything else we want to cover off on in abdominal emergencies?
I think we covered a lot.
I think we're good.
I think we got it.
Hit it all.
We did. We got all the notes.
All the abdomen stuff.
But I encourage you all to stick with us, to join us again next week. Next week, we're going to be talking about resuscitation, bringing people back from the dead.
Literally.
Yeah.
Like that person was dead. Now they're not.
Now they're not. So a quick shout out to our Tools of the Trade sponsor for next week, and that is going to be Defib Tech.
So sexy.
With Masters Medical Equipment, a co-sponsor. They have sent us a AED, an automated external defibrillator, which we'll be talking about, AED usage. And, basically all the things that, while this episode has been things that we can't really do, there's some things that we can do.
Oh, yeah. All the things.
When it comes to the resuscitation space, which is awesome. That's the bread and butter right there. The things that we're excited for because, hey, we can help people right now.
Yeah.
Bringing people back from the dead.
Yeah. So stick around. Make sure you're listening next week. We hope you guys are all enjoying the podcast. We love going through it with you. We really just want to say thanks for taking the ride along with us. And until next time, we'll see you on the ride along. This podcast is for educational and storytelling purposes only. It is not medical advice or official EMT training. Always follow your accredited instructors and local protocols.
Heartbeats racing in a